So let me say good evening, my brothers and sisters, for this special Thursday evening edition. I am grateful to have a friend of Messiah. He is not a stranger to us, but there may be some of you who might be part of our virtual membership, and you have not seen or heard from Dr. Alexander Salerno. So I'm grateful that he's taken time out of his schedule to meet with us so that we can have this one-on-one candid interview about COVID, about the vaccine, about where we go from here. So Doc, I'm going to introduce you, and then just tell us a little bit about yourself, your practice, and how long you've been in medicine.
Thank you, Reverend. So I'm an internal medicine physician, second generation. Mom, dad started in East Orange, dad in Newark, my mom in 1952. I joined my parents in 2001. I'm internal medicine. We have a pretty large practice, multi-specialty at this point, beside primary care. I'm big into population health. I did a master's in public health and health administration. And so I understand the importance of public health now more than ever, with COVID clearly exposing us as a country and maybe the lack of public health. I started about 20 years ago, House Call for Senior program called SHOP. And then, as you know, about 10 years ago, started a non-for-profit regarding healthcare literacy and working with different denominations and different faiths about improving disparity in healthcare through knowledge and facts. Because I find, and studies have shown, a lot of consumers and patients make decisions based on fiction and not on facts. And so, between the non-for-profit and the population health programs, I really focus on healthcare in the community and try to be more proactive and less reactive. And you taught me, fear is an emotional sin. And we know a lot of people fear healthcare, fear doctors. So they clearly make bad decisions when they have fear in their minds. We all do, could be any decision. So that was an important lesson that I apply every day when I talk to patients in my office or anywhere. Just, displace the fear, instill facts, and conquer fiction. Okay. And so I think we need that really now with COVID. Absolutely. And especially the vaccine, because I am getting a lot of pushback when I talk and when people mention the vaccine, especially to certain communities like African-American community, Hispanic community. And people in general, even people just, I think, don't understand it and are kind of like California wildfire, just taking off with crazy connotations.
Okay. So Doc, before we get into that vaccine conversation, 9 months of COVID, from mid-March up until now. Tell us, you talked about fear. What can the average person feel about COVID in December of 2020 compared to March 2020? What has changed? How has the medical practice sort of attacked it before we get to the vaccine? Where are we now with COVID?
So from a medical community, we know a lot about COVID. We learned a lot in a very short period of time. How we manage it and how we approach it now is a complete 180 compared to what we did in March and April. March and April, we did and went to early intubation and mechanical ventilation. We didn't have any drugs at all to attack it. We knew it was a virus. We didn't know anything that it could be sensitive to. We were against using steroids of any kind at that point. We thought it was the wrong thing to do. Now, fast forward, and through, medical insight, communication, and the medical community really sharing a lot of information, we know we, do not want to intubate the patient unless we really need to. High flow oxygen can help bridge patients. We know
when you say intubate, give us a quick, what's that?
So we mean putting you on a life support, putting you on a tube down your throat into your lungs, and the machine does the breathing for you. So mechanical ventilation. So we know that's not the thing to do, early on. We know there is a value for steroid use. And we do have drugs that help. And I think the important thing that we know is early detection, early intervention. We know certain people don't do well with COVID. Overweight people do really, really bad with COVID.
Okay.
Diabetics do really bad with COVID, but definitely overweight. Overweight people are getting hit harder, carrying it longer, having a harder time clearing it. So obesity, we always knew is not good for your health to be big, but it's not good for COVID health either to be big.
Okay.
And so right now, if we can early detect a patient, and the other thing, as you know, in March, April, we couldn't test. We didn't have supplies to test. So we had to choose who gets tested and who doesn't. We had to ration care, because we couldn't test. Now we could test anyone, everyone, all the time. We could test and test again and test again. And I think that's important. People need to know that just because you got tested once and you cleared it, doesn't mean that you can't get infected 2 days from now.
Okay.
So it's important to get tested frequently. And it's really important, as I keep telling everyone, they should know their antibody status.
Okay.
Because antibodies is your Superman cape, to protect you and shield you.
Okay. So in getting an antibody tested, that's different from the rapid test. Is that right? What's the
Correct.
nose swab? Like, what does that, because I think some people think that if they get the nose swab, it comes out negative, they're good to go. But
they're good to go until 5 minutes from now when they walk into someone or find themselves in another area. So, I can't tell you how many hundreds, if not thousands of people tested negative 1 week and tested positive a month later or 2 weeks later.
Okay.
So testing has to continue actively and aggressively. And so to answer your question, the swab or the rapid fast, there's two kinds, right? There's the rapid fast that you could get an answer in 15 minutes.
Okay.
That's looking at the antibody. That's not a very accurate test, meaning that if it's negative, that's showing that you don't have the virus, you still could have the virus. If it's positive, you pretty much have the virus. Okay. So a positive is very confident, and a negative is not 100% confident. That's the rapid fast antibody. That's the Abbott lab test, And I mean, as everyone knows, earlier in the year, there was a big outbreak at Washington, D.C. and with Trump and the whole cabinet.
Yes.
And they constantly were getting tested with the Abbott test because they needed to turn around within 15 minutes. Unfortunately, the Abbott test was not 100% accurate. There were positive people, and then all of a sudden, 20, 30 people, including the president, contracted COVID as a result of the rapid fast Abbott test. It just wasn't 100%. The real deal is the swab, the nose, the throat, or the saliva, and that you have to send to a commercial lab, and it's a PCR test. So think kind of like Miami CSI dealing with DNA, really good stuff. Okay. And that's accurate point on if it's negative or if it's positive. And that's how you determine acute infection and infection and being infective. The antibody is a blood test. And the antibody tells us, do you have circulating antibodies to signify that, hey, I was exposed to COVID. My immune system responded to COVID. My immune system has created now an antibody, kind of like, that's your immune system's 24-hour policeman standing guard in your system, monitoring for COVID, particles, future COVID particles. The thing is with antibodies, it's important because if you have it, it's as good as a vaccine to protect you. You could still get reinfected. Don't get me wrong. Nothing in life is 100%. No vaccine is 100%. No treatment is 100%. No antibodies 100%, but it's pretty darn close.
So if a person tested positive, and then, tested negative, and then months later test positive again, would their symptoms be the same, or it'd be less of an impact of COVID the second time around? Or has that been determined yet?
So here's the thing. So I can tell you from my personal experience, we've tested close to 40,000+ New Jerseyans.
Wow. Okay.
Since March 17.
Okay.
we have had about 3 to 4 people reinfected with COVID again after having had COVID. One thing that is common denominator to all these 3 people, they're all in the healthcare field. So they
Okay.
clearly have high exposure,
Okay.
constant exposure.
Okay.
What I will say is the second time around when they were reinfected, and active reinfected, meaning the swabs were positive, and they had still antibodies. So they had antibodies.
Oh, wow. And still tested positive. Okay.
And the swabs were positive while having antibodies. They had 0 symptoms, not even a runny nose, not even a scratchy throat. The concern is, though, they now become silent spreaders. So they're not sick. They're not dying, God forbid. They're not going to an emergency room. They're not stressing the healthcare system, but they're potentially getting friends, family, neighbors,
Infected.
strangers sick. So that's the concern.
Okay.
That's why, as you now hear and read about, people in the healthcare industry, nursing home staff, they're being tested weekly still.
Okay.
So we can try to catch people that may become repeat infectors.
Okay. Before Doc, we shift our conversation to the vaccine. Let me ask one more question. So let's say I go in, I get tested, my test comes back positive. What steps do you recommend an individual takes? Like before they freak out and become fearful, walk me through like what steps should I do once I get a positive test back?
Okay, so the first thing you want to know, anyone and everyone you came in contact with for the 5 days prior to your test.
Okay.
Because chances are definitely 2 to 3 days prior to your test, you were infectious.
Okay.
And you were now spreading. So you'd really, this virus is so infectious, is so spreadable, is so communicable that it's really important we do like a dragnet approach to who were you around. That's number 1. Number 2, speaking to your healthcare provider, you have to know, okay, and again, we've seen healthy people go down with COVID. We've seen sick people go down with COVID. And we've seen sick people, meaning people with diabetes, hypertension, COPD, have no symptoms from COVID. So you've seen all ranges and kind of spectrums of COVID. But again, we know obesity, age, diabetes, hypertension. So if you fall into that risk category, you really want to consider, 1, you have to invest right away in a pulse oximeter that you could buy at CVS or Amazon for $5-6.
Okay.
Because you need to be not only monitoring your temperature, you need to be monitoring your oxygen level. And that's what a pulse oximeter does.
Okay.
Because it's kind of sneaky the way the COVID works, but it catches up to you. And 1 minute you're at 98% oxygen. And then a day or 2 later, you could be down to 92% oxygen. Wow. And that's that window that you have to then start really seeking medical attention. And that most likely is going to be hospitalization.
Okay.
Because you want the remdesivir, which is the drug that you've heard about.
Yes.
And only comes in an IV formula. You want to be able to receive high flow oxygen. And you want to start having blood monitored because there are blood tests that correlate with the activity of the COVID.
Okay.
So we can see COVID climb like a Richter scale by monitoring certain factors in your blood. There are inflammatory factors in your blood that can correlate with COVID activity.
Okay.
And COVID activity correlates with severity of COVID, complexities of COVID, and risks of COVID. So 1, you need to know you have it. 2, you need to be monitoring your pulse and your oxygen 3-4 times a day. 3, you need to know what other co-risk factors you have. 4, you have to also realize that COVID is like a camel with a hump. There's a hump, a valley, and a hump again, meaning that you kind of feel achy the first couple of days. Maybe that's what brought you to the doctor to get tested.
Okay.
Then you start feeling kind of okay, right?
Okay.
And then days 5, 6 into it, it hits you like a brick. So you get this false sense of confidence between days 2 and 5.
And then
it hits you. So you're not out of the woods for the first 8 days.
Okay.
You're not. Okay.
Am I taking what, Tylenol? Just
You're taking,
best.
so, well, obviously, we love vitamin C, we love zinc.
Okay.
You definitely want to go to an adult aspirin, which is 325 milligrams,
Okay.
maybe twice a day,
Okay.
because we know COVID can cause blood clotting disorders that can lead to stroke and heart attack
Okay.
and also clots in the lung. We know vitamin C is good for your immune system. We know zinc is good for your immune system. We give zinc and vitamin C to active COVID patients along with the steroids and the remdesivir because we think it may help a little bit with either viral replication of COVID or viral COVID penetrating our cells and
Okay.
replicating repeatedly in our cells. So you want the vitamin C, you want the zinc, and you should take it with food because anyone who's taken zinc on an empty stomach, you're gonna get nauseous and you're gonna get queasy and you're gonna
Yes.
get a lot of GI distress.
Yes.
And adult aspirin, everyone has some degree of gastritis, so you want to take adult aspirin with food as well.
Okay.
And again, in conjunction with your healthcare provider, so everyone's on the same page. But you want to, these are the things: vitamin C, zinc. We are, studying melatonin. Melatonin not only is good for sleep, it has some antioxidant benefits. It might help with that COVID brain fog that you hear about. Okay.
Okay.
The vitamin D has been demonstrated to help. Obviously, we said the aspirin, and there's some other things that we're looking at like glutathione, curcumin. So if you look, after America, the other country really spiking in COVID is India. But when you look at the mortality, and India is a much larger, denser population than we are here in the US, India seems to have less mortality. And one of the reasons we think is there's a lot of curcumin in the diet in India.
Okay. That's good.
And so we're thinking maybe, again, this is what we think at least, so, but definitely early detection, early diagnosis, close monitoring, and be quick when that oxygen level goes down that you get and you seek hospital attention.
Okay. Okay. So last week the FDA approved the first vaccine from Pfizer. I think Moderna was approved this week. Whole lot of discussion in our churches and in our communities, Doc, about this vaccine. Now, first question. In the past, I've read where it's taken years for vaccines to be developed. And there are those in our communities who are already hesitant because in less than a year, we have a vaccine that's created and approved and being pushed to the public. So tell us about the technology of this vaccine that differs from the vaccines of the past.
So a vaccine is a word, it's a noun, vaccine, right? Or to get a vaccine. And so there are a lot of different types of vaccines. There's viral vaccines, bacterial vaccines, dead vaccines, live vaccines. And when we talk about COVID, we're talking about mRNA, M standing for messenger vaccine.
Okay.
So when you talk about years to market, years in research and development, you're talking about historically live or dead bacterial and viral vaccines. So if you're going to make a comparison, you have to compare apples to apples. You can't say I drive a car. That's great. But is it a convertible? Is it a pickup? Is it domestic import? Is it exotic? What is the kind of car? You're just giving me a very generic term. So vaccine is a generic term.
Okay.
But now let's talk live, dead, bacterial, viral, mRNA. COVID is an mRNA vaccine. So mRNA vaccines can go through the process a lot quicker and a greater volume than the historical flu pneumonia vaccines, which were dead or live bacterial and viral vaccines, where we're dealing with actual particles of the actual illness.
Okay.
mRNA is not a particle of the actual illness, polio, measles, these were vaccines which historically polio was devastating. I'm sure a lot of your members of the, of the congregation remember polio. It took a while to get the polio vaccine right, but it was a live vaccine, and we had to recreate and master particles of the virus to as part of the vaccine process. mRNA is different. mRNA, first of all, also, mRNA technology has been around for nearly a decade. mRNA technology has been used in cancer. mRNA technology is used in melanoma cancer.
Okay.
And melanoma is one of the fastest growing cancers in our society right now because of sun and lack of skin protection. And, and anyone could get melanoma,
Okay.
So it's used and has been in cancer. It has been used in Ebola and Zika viruses. And now we're using it in COVID virus. And so what we're doing basically, mRNA, and the key word here, M is messenger. So we are introducing let me take a step back. Viruses and bacterias have, like a human, they have a protein, okay? Just like us humans have a skin around us.
Mm-hmm.
Viruses and bacteria have protein. These proteins, like a saran wrap or something, is around their genome and around their own DNA, for lack of better words, because viruses, imagine, are living, breathing things. So when we targeted specifically COVID, and you've seen the cartoons where COVID has these spikes, right?
Right.
And we know these spikes are very important in the viral replication and viral introduction process into our bodies. mRNA technology, basically, we introduce into in this vaccine that enters the human body, that sends a message to our own DNA about this spike protein.
Okay.
And says, hey, have you seen this spike protein? And it shows it to our immune system. And our immune system then responds to this message and passes it on to the other immune cells in our body to be prepared that if we see this live protein coming from the actual COVID virus, to destroy it. So we are kind of training, messaging our own DNA, our own factories about this spike protein, and making our own DNA kind of recognize it, put it to memory, and be ready that in the event COVID does enter our body at any point in time, the real deal McCoy, it will not be able to do its thing because the immune system has already recognized it and developed a defense against it. Antibody defense and what we call immune killer cells. Our immune system can develop killer cells that will go out and kill the virus if it enters the body.
So the vaccine works as sort of like a security system, a hired gun, so to speak, so that if COVID enters our bodies after the vaccine, our bodies, not the vaccine itself, but our bodies know when to fight it off, know that, hey, this is something that should not be in us, and it goes and
exactly
and kills
it. Recognizes it as foreign. Our own DNA has been given a message, right? A message on the message RNA vaccine. This spike is not good.
Okay.
Make and be prepared to recognize it in the event that you come across it in the supermarket, in the hair salon, in the restaurant, and wipe it out. And that's why, for example, this vaccine, as you've seen in the clinical trial studies, 95% effective with 2 competing pharmaceutical companies, 95% effective. As a reference, okay, for all of those who are like, oh, this is like the new kid on the block, we want to still, deal with like the flu and pneumonia vaccine that's been time tested for 20 years. Well, last year's flu vaccine, Reverend, was 45% effective. Okay. Wow. 45% effective. And how many decades have we been working at the flu vaccine?
Right.
And last year, up to 62,000 Americans died from the flu. So, just because it's new, first of all, it's not, because I just said it's been around for 10 years, the technology at least. It's been used in cancer. It's been used in other viruses. So it's not new. Second of all, let's not say that we're cutting corners, because we're not cutting corners. This vaccine was introduced in animals first, and then it went through phase 1, 2, and 3 trials like the traditional bacteria and viral vaccines of old. We did not cut corners. We
Okay.
sped up the process, but we still went through animal phase 1, 2, and 3. Normally, when we do trial studies, we wait till phase 3 is done, we sit back, and we like to review everything in one shot. In this case, we did rolling reviews after phase 1,
Okay.
during and after phase 2,
Okay.
during after phase 3, because we didn't have the luxury to sit and be able to wait till all the dust settles down, because I mean, you see the numbers right now,
Right.
you know,
Right. Right.
and so, you know, I'll be honest, I've never done the flu vaccine myself. I'm 53 years old. Okay. I'm reasonably healthy. I'm already signed up for the Pfizer vaccine. I will definitely get this vaccine.
Okay.
It is also common for any vaccine, live or dead, to have injection site reactions. That's normal. What's an injection site reaction?
So what's your, yes.
Redness,
Okay.
pain, swelling from your, bicep down to your elbow, okay? And you can still have a low-grade fever for up to 2 days.
Okay.
But if you compare actively infected with COVID to an injection site reaction and some achiness for 2 days and a low-grade fever, it's a no-brainer.
Okay.
Especially if you're going to get 95% protection.
You spoke of, Doc, earlier, this messenger. Other comments in the community have been, and so, and Doc, you and I have talked, we've talked about this offline, but you know that there's a hesitancy in the African-American community regarding vaccines.
Yes.
From the Tuskegee experiment to just so many experiments that we were guinea pigs. And
Correct.
so there is an apprehension in our community about vaccines. Now, you spoke of this messenger. Let me ask this. Can the messenger vaccine determine an African-American person from a white person, from a Latino, or is it a vaccine? Like, so can you dispel some of that?
No. First of all, this messenger vaccine is not going to be a tracking tracing tool that the government can follow us. I've seen like crazy ideas of that. I mean, let's displace this.
Okay.
It's not going to enter your DNA and change who you are and change the legacy and the trajectory of your family gene pool. Okay. So your offspring will all of a sudden have 6 toes or anything like that.
Okay.
This virus comes into your body. No, I'm sorry. The vaccine comes into your body. It doesn't last long in your body because it kind of like, I don't know, for those of you who remember, like, Mission Impossible, and the message will explode in 10 seconds after you've gotten the insight of what you need to do. Well, this vaccine, it becomes destroyed within a few days of being inside our body. It just doesn't sit there forever. That's why we need 2 shots too, because it's a 1-2 knockout punch. Because it doesn't last forever. That's why you're also seeing the challenges right now of the vaccine are shipping, storage, shelf life. So that clearly tells you that this vaccine is not going to be hanging around inside you for weeks, months, decades, or a lifetime, like, unfortunately, the syphilis experiment of the 1930s. And again, that was then. This is now. COVID is affecting all of us, all colors, creeds, races, and everyone right now. And we all need to take this and consider this vaccine and take this vaccine. There's a small percentage of people who shouldn't take it, those who have severe anaphylactic reactions, which I can tell you, I don't know of one, maybe one patient in my entire practice that has that type of high sensitivity reaction. And even then, when we give the vaccine, we monitor you for 20 minutes before you leave. We have an EpiPen, God forbid you happen to be that, 0.111% person, okay? And, I think also a good idea with the vaccine, just to like reduce some of the maybe, typical inflammation and hyper response that we may receive from it, is to take a little Benadryl and a Tylenol half hour before getting the vaccine. and then expect swelling, pain, and that's Tylenol and ice pack and 2 days.
Okay. So you said you signed up for it. I know I'm
Yes.
gonna sign up for it. So convince the viewer why they should take it. Because there are some who say, I'm just gonna wait out. Some are saying, let the first group go first, see how it responds, and then I'll take it afterwards. Why should we be ready to take it immediately?
Because taking it immediately, you have a 95% chance of not getting COVID.
Okay.
Not taking it, knowing how infectious it is and seeing the numbers, you're gonna get COVID.
Okay.
And you may not live.
Okay.
And it's not just, unfortunately, getting over COVID, Reverend, that's the challenge. Everyone's heard about the post-COVID patient, the long hauler syndrome, right?
Mhm.
You
Yes.
see young people becoming disabled from COVID.
Yes.
You're seeing people with cardiac damage, heart damage after COVID, lung damage after COVID, neurologic damages after COVID, unexplained memory issues, thought issues, neurologic pains. And that's lasting months and months and months. And we don't yet even have an antidote for that.
Hmm.
So COVID is not just, it hits you, you get over it in 10 days and you move on.
Like a cold.
Like a cold.
Okay.
It hits you, and then it decides, maybe I'm going to stay around for another 6 months, a year, or the rest of your life.
Okay.
And so, I don't know, if I, God forbid, were to get COVID, I'm worried more about the post-COVID hangover, if you would, okay, of headaches, blurry vision, shortness of breath, heart conditions, blood clotting conditions, neurologic damage, unexplained pain, twitches, fatigue. I mean, at the end of the day, we always talk about it's not just living, it's the quality of life. So, and look at the COVID, you hear about it, we're talking about the COVID pandemic fatigue. We're tired. Right. We're all tired.
Yes.
We're tired. People have been robbed of a year of their life.
Of all activities.
Yeah.
Yes.
I mean, Thanksgiving, we did not spend with family. And if we did, we put them at risk.
Right.
You haven't seen your mother. I barely see my mother. I mean, and that's a year we're never going to get back. And when we get into our 80s, every year is a gift.
Okay. All right.
So.
Okay. Well, Doc.
Get it. And you're going to get it.
Yes.
And we're going to get pastors and politicians and everybody behind it.
We're going to get community leaders to get involved with this.
Unified message.
Last question, Doc. So I know that we have initial rollout. What's your best guesstimate that it's available to the public at large? Give me a time frame if you have it.
So, as you know, right now it's first responders and it's nursing home and assisted living patients. And then, it's going to go to the next bracket, which is the elderly in the community and chronic disease state, cancer, dialysis, things like that. But I think for like anyone and everyone to get it, just like one would get a flu shot, let's say, I'm hoping that probably early first quarter, February, maybe end of February, because we have Moderna. J&J has one coming out. There's a lot of companies that are now standing in queue. And like we talked about, there's right now they're all 2-shot processes. There is talk of a 1-shot process, but that's going to be later in the spring. But I definitely would hope that by no later than Easter, we will be having a great celebration.
That we can,
not just for the rebirth of Christ, but for the defeat of COVID.
Amen.
So,
amen, Doc. All
right.
Listen, everyone, I want to thank you all for tuning in. We want to thank Dr. Alexander Salerno for taking time out. This is probably part 1. We'll probably revisit this conversation sometime early part of the year or next year, just to keep pushing this discussion. Thank you, Doc.
No
God
problem,
bless you in the work you do in our community. And
Merry Christmas to everyone.
Yes, Merry Christmas, Happy New Year.
Make sure everybody knows their antibody status. Very important. Okay.
Get your antibody status. All right.
Yes. Okay.
Thanks, Doc. Have a
All
good
right,
evening.
Rev.
All right, take
care.
care. All right.
Go Steelers.
I won't even say about the Cowboys. That's
Yeah,
it, Doc.
no, next year.
Yeah. Take care,
All right.
Doc.
Later,
Thanks.
Rev.
Okay.